Can AI detect orthodontic relapse? Colleagues, I recently read a very interesting study from the Harvard School of Dental Medicine that raises a question which, in my opinion, we will be asking increasingly often in clinical practice. What is the role of artificial intelligence in dentistry, and can AI detect the onset of orthodontic relapse while the patient is still at home, before the orthodontist even has an opportunity to perform a clinical examination? Following completion of orthodontic treatment, the challenge is not simply how well we have aligned the teeth, but how effectively we can maintain that result. Conventional retention follow-up appointments are scheduled at predetermined intervals, but tooth movement does not follow our appointment schedule. Changes may begin between two visits, the patient may not notice them, and by the time we finally identify the problem, a minor displacement may already have developed into clinically visible relapse. What follows may sound somewhat futuristic, but as artificial intelligence continues to advance, it could soon become part of everyday clinical reality. Let us begin with the study entitled Evaluation of an AI-based remote monitoring system for detection of post-orthodontic anterior tooth movement, authored by Lake Jesse Seymour. The study evaluated the dental monitoring system, which enables patients to capture images of their teeth at home using a smartphone and a ScanBox device. Artificial intelligence integrates these images with the baseline intraoral scan, reconstructs a three-dimensional model, and monitors changes in the position of individual teeth. When movement exceeds a predefined threshold, the orthodontist receives an alert. The threshold was only 0.4 mm for incisors and 0.6 mm for canines. In other words, we are talking about tooth movements so subtle that patients may not even be able to detect them when looking in the mirror. The initial study population included 80 patients and 160 dental arches, while the final analysis included 76 patients and as many as 912 anterior teeth. Each of the 12 anterior teeth was assessed individually, and the determination of whether tooth movement had occurred was made independently by the algorithm and two calibrated human evaluators. What interested me most was the extent to which the AI system actually agreed with human assessment. Overall agreement among all three evaluators was high, with a Fleisch kappa value of approximately 0.77. When the algorithm was compared individually with each human evaluator, agreement was also substantial. This does not mean that artificial intelligence reasons like an orthodontist. It does, however, indicate that its decisions were not random and that, in a large proportion of cases, they corresponded with human assessment. An even more interesting finding emerges when we examine how frequently each evaluator classified a tooth as having moved. The first evaluator had an estimated probability of detecting an irregularity of approximately 21%, the second approximately 24%, and the algorithm approximately 20%. Thus, across the entire anterior segment, the difference between human and machine assessment amounted to only a few percentage points. However, the study demonstrates something that may be even more clinically relevant: not all teeth appear to have the same probability of movement. The highest probability of irregularity was observed in the maxillary central and lateral incisors, where it reached approximately 32 to 47%. For some canines, the probability was only approximately 8 to 12%. For me, this is one of the most important findings of the study because it suggests that we may need to think less about retention as a single uniform protocol applied to the entire dentition and more about monitoring individual teeth that may be particularly susceptible to post-treatment positional changes. There is, however, an important detail that should not be overlooked. For the maxillary incisors, the AI system was frequently more conservative than the human evaluators. The largest difference between any two evaluators for an individual tooth reached approximately 16 percentage points. For this reason, I would certainly not interpret this study as evidence that an algorithm can replace the orthodontist. On the contrary, the real value of this technology lies in its potential to function as an additional digital observer between scheduled follow-up appointments, a highly useful tool supporting the clinician. Imagine a patient whose retention is beginning to fail. Instead of discovering the problem several months later, the system could potentially identify and report the change much earlier. We could then assess retainer fit, modify the prescribed wear regimen, or invite the patient for a targeted clinical examination. However, it is important to remain scientifically precise. This study did not demonstrate that artificial intelligence prevents orthodontic relapse, nor did it establish that AI-assisted monitoring reduces the need for retreatment. The study was retrospective, only anterior teeth were analyzed, and aesthetic outcomes, quality of life, and actual retreatment rates were not evaluated. Therefore, this is how I would present the study to colleagues. It does not demonstrate that artificial intelligence will replace the orthodontist. Rather, it suggests that AI may become a highly valuable early warning system for detecting post-orthodontic tooth movement.